Welcome everybody. Thanks very much for joining us over this lunchtime for the first of 6 sessions as part of the PoCoG virtual ASM. And obviously I'd like to welcome you all and remind you, of course, that as I said, this is session 1 of 6, so please don't forget to register for the other 5 sessions happening this week and next week, and you can find the links to that on the PoCoG website, as well as looking at the e-posters for that are also available for the PoCoG meeting as well. So welcome everybody. Today I'm going to be talking to you about the learnings that we have from the implementation of the clinical pathway to identify and manage anxiety and depression for patients with cancer. What we knew then and what we know now. And this, of course, as many of you may be familiar with, this is the large program of work called the Adap program, which PoCoG, the Psycho-oncology Cooperative Research Group, have been working on for the last 6-7 years plus. Before I start, I would first like to acknowledge country, and I'd like to acknowledge the Bidjigal and Gadigal people of the Eora Nation, upon whose ancestral lands I'm speaking from today. And I pay respects to elders past, present and emerging who have cared for and continue to care for our country. And I acknowledge them as the traditional custodians of knowledge for this land. So today's session we've split it into, I guess, 3 larger parts, and then the last part, part 4, will be a bit of a discussion section. But the first part will be led by myself and my colleague Sharon He, one of the research officers as part of the Adap program. And we'll be talking about introducing the Adap clinical pathway, engaging services and staff in preparing to implement new processes within cancer services. So as a brief summary, many evidence-based clinical pathways have been developed, yet their impact on health outcomes is unclear. The Adap clinical pathway was published in 2015 and was developed in response to clinical need to support cancer services to integrate evidence-based psycho-oncology care. The Adap cluster RCT, the randomized controlled trial we'll be talking a lot about today, commenced back in 2017, with 12 cancer services recruited to test implementation strategies of the clinical pathway into routine care over a 12-month period. So to support the Adap clinical pathway implementation, the Adap program within its large research body of work has involved several studies where interventions and resources have been developed. And this really illustrated that much preparation is required to make these things happen. As we learned and we knew that one document is not enough to change practice. So the Adap clinical pathway as I said, is about the identification and management of anxiety and depression in adult cancer patients. And what it's based on is obviously best available evidence to recommend screening, referral and management. And the idea of the pathway is to provide clear treatment pathways based on symptom severity. And it uses a stepped care model to kind of triage or categorize patients into one of 5 steps. And in order to kind of work out which would be the best interventions and which support might be best for them, with the idea being that the most intensive interventions are reserved for the patients who require specialist mental health treatment. So this slide shows, as I indicated earlier, that to support the Adap clinical pathway, infrastructure, education, information and therapies using new technology can enable patients with cancer in Australia to acknowledge and access support when they're needed. So as we said, one document is not enough. So in the middle, we have the Adap clinical pathway, but around it, we also developed a number of different resources. The Adap portal, where patients could complete screening at home via email or in clinic using the tablets, and where staff can monitor screening, patient-reported outcome completion, and the triggered alerts according to the clinical cutoffs based on the screening tools. We also developed the EverQ online training available to clinical staff, as well as an online therapy called I Can Adapt, which was developed with the Centre for Research for Anxiety and Depression in developing this new program for patients to support and address their mental health if that was identified and if that was something that they wish to do in that format as well. Of course, lastly, we had some patient resources as well, which we developed, which enabled us to provide universal and tailored information to the different cancer services. So we had some generic information that was appropriate to all, but also services were able to add in their own local support groups and information about things local to them. So within the Adap clinical pathway, obviously one of the first things is that it recommends introducing screening, and we built this into our Adap portal as a two-phase online screening process where patients completed either the ESAS or the distress thermometer, and these were decided by the services. And then if they had triggered particular cutoffs, they were then seamlessly forwarded on to complete the hospital and anxiety depression scale. Within the portal, we had a number of portal alerts that we developed, and we used a traffic light approach to kind of flag to services and to the staff within the services about which patients had triggered above certain cutoffs and above those points within the clinical scores. And so these alerts were sent to the staff responsible via either a portal alert, an email, or an SMS, which as the portal has that capacity, and also gave acceptable timeframes for services to act on the alerts. So our implementation trial, which is the Adap cluster RCT, this pathway obviously, was developed for anxiety and depression in patients with cancer. And the implementation strategies were also developed to address some of the identified barriers that we had to implementing the Adap clinical pathway. And we developed strategies that included tailoring of the clinical pathway to local resources, obtaining detailed feedback from staff to allow for adaptations to be made. And these were done, as part of the cluster randomized controlled trial. So the Adap clinical pathway was implemented for 12 months in a randomized controlled trial and evaluating two different levels of implementation strategies, core versus enhanced. So this slide just gives a bit of an overview of our cluster RCT trial design. So as I said, the preparation for implementation of the trial happened with the 12 sites, and we had between 6 and 8 engagement meetings with each service, and all of this was the same. And it was only as we got to the go live period and over the 12 months that the two different arms emerged, and one set of services were randomized to the core arm, and one set of services were randomized to the enhanced arm. And throughout the trial, we essentially were seeking feedback and evaluating data from the services and from the staff. These were the key research participants in our study. So as I said, one of the key elements was tailoring of the clinical pathway, and we had a number of different things, which I'll talk more about in the next little bit as well, is around tailoring the clinical pathway. So we had some elements that we needed services to make decisions around, and these were around the screening tool, timing of screening, role responsibility, and local referral networks, as well as local resources and information. So that's been a little bit of a background of the Adap clinical pathway and the trial itself. But what we're going to do now is go on to talk a little bit more around some of the data that we have from some of the first, from the early part of our study, where we were engaging with the services to implement and tailor the clinical pathway for each service. So I should, of course, acknowledge that this work is part of a large research program, the Adap Cluster Randomized Controlled Trial, but it's part of a large program funded by the Cancer Institute New South Wales through the Translational Program Grant Scheme. Sorry, talking live. It's funny after being recorded and trying to get my words right. So where obviously our focus is on psycho-oncology and supporting psycho-oncology services across cancer care in New South Wales, we were also really interested in investigating and understanding implementation processes and outcomes. So the analysis that I'm going to talk about now is focused on the tailoring decisions that each service made to operationalize the clinical pathway and the 7 components that you can see in the diagram. So you can see introducing screening was one of the key things, and then that whether to do that at the first and then the first or initial screening for patients that were introduced to screening, then step allocation based on one of those on the screening tools, either the ESAS-R or the distress thermometer, plus or minus the HADs as well. And then step allocation was made based on the algorithm behind those screening tools. A triage conversation with a clinical staff team member to confirm and clarify identified issues, and then discuss the level of support indicated and preferred by the patient. And then moving on to referral, progress review, to check in to see whether the referral was meeting the needs of the patient, and then back to rescreening. So these were the steps that the services need to discuss in order to tailor the pathway. So as I said, we had 12 services, 7 in urban metropolitan areas and 5 in regional areas, regional services in New South Wales. And each service formed a multidisciplinary lead team. And this lead team was there to obviously make those decisions around the service. So the lead team, led by the Adap team, discussed how these components would be actioned, with decisions being for the most part made within these engagement meetings over 3 to 4 months before the implementation. Flexibility within the clinical pathway enabled services to make decisions based on their own staffing capacity, service processes, and patient flow. As a core component of the clinical pathway is to introduce and integrate regular screening, and then based on those screening scores and triage conversations, recommend support and rescreen. To document all the decisions that we made and that were made by the cancer service lead teams, we used meeting notes and workflows that were produced for each service at the start of the implementation. And these came about by following some structured agendas that we had set up to ensure that all operational and clinical decision points were covered. Lead teams had diverse multidisciplinary representation. So there were nurses, psychosocial staff, non-clinical managers, IT, admin, medical staff, clinical trial, and other allied health team members as part of the team. The greatest proportion of the team, as you can see on the slide here, was mostly nurses. So a mean of 39% of nurses across all of the teams, followed by psychosocial staff, non-clinical managers, IT and admin, and other staff. So we had a bit of a mix, as you can see, across the lead teams service. So across all of the engagement meetings, as I said, we held 80 meetings in total, and most services there was a mean of 7 meetings per service, ranging from 4 to 12 in person. We had differences in terms of meetings being held in person and via teleconference or web conference, and most meetings, and the mean length of time for each of those meetings was 53 minutes per meeting. So for the Adap clinical pathway and its operationalization, it was during the engagement meetings that some elements of the Adap CP were presented by the research team as fixed, whereas others included options where services could choose to tailor to the needs and their population. So these were the more adaptable ones, and you can see those in the orange and the green on the right-hand side of this slide. So lead teams discussed these over the course of those engagement meetings prior to going live. And I'm going to highlight some of the examples over the next slides with rationales for some of the decisions that were made in relation to those. So this slide shows a summary of the first decisions tackled, the patient cohort, and how and when to introduce screening. Services had the option to include all or a subset of patients in the Adap clinical pathway, and they of course differed in their decision made based on local rationales. Deciding at what point to introduce the concept of regular screening to patients resulted in differing approaches too, with services balancing the issues of not missing patients by introducing during existing information contacts, or holding off until new patients were a bit more familiar with the service and with treatment plans. So these were the ways and the rationales that services made their decisions around patient cohort and when to introduce screening. In terms of the next decision was around selecting which initial screening tool was selected. And as I said earlier, there are 2 initial screening tools that the clinical pathway recommends. So services selected the tool that was often based on prior experience using paper versions in some circumstances, or the use of one tool in research projects that they may have participated in. And essentially, obviously, looking for the best fit with their patients and with other services within their wider or greater hospital fit or across the cancer service. So screening modes that services could and would support also differed. The Adap portal supported email, in clinic or phone. And so different services elected to either offer all three or a selection of one or two of those three options. And finally, the screening interval, the rescreening interval varied depending on how long between screens each lead team felt fitted with their patient cohort best. So most services opted for screening every 3 months, but obviously some services elected for difference based on their particular patient cohorts. Following screening, the Adap clinical pathway recommends a triage conversation to confirm step allocation. And to review the patient problems that patients may have also checked or get with the problem checklist that went with each of those screening tools. Most services adhere to recommendations based on the allocated severity step. And also, they also adhere to who would take on the different role or the different triage conversation roles. So you can see there. So nurses were often allocated the role of triaging for milder symptoms, whereas the psychosocial team for those that, symptoms that were more moderate to severe symptoms, so step 3 and 5. Services were also able to nominate time to complete this conversation before reminders and escalation process were initiated within the portal. And obviously, many services opted for a shorter time frame for patients who had a higher severity step. Lead team discussions about who would, about what was required for each Adap role and who would be able to do what was a lengthy topic of conversation in most services, with rationales for decisions based on acceptability of the role, capacity, skill set, etc. But once decisions had been made, we created individualized workflows for each service as a record, and we use this also as a communication tool and to assist with kind of looking at how the services were adhering to their decisions made at the beginning. And that's that rather complex diagram on the right-hand side. So what we've highlighted here is that there's real practical issues and staff attitudes and skills really guided the clinical pathway decisions around how to set it up for each service. And it really highlighted the need to work collaboratively with each of the health services and ensuring that we allowed time and that ensured that the right people as well were involved when tailoring new clinical pathways or any new clinical initiatives as well in setting something up to implement across a new service. So documenting this detail has actually been really important, just to illustrate, this engagement is a really important part of engagement and ownership, but also to show that this time taken to carefully plan is a really important process, and being able to present both fixed and adaptable elements engage services in this process of collaboration and collaborative decision making to resolve some of those issues. Thank you. So I'm going to just hand over, I'm going to stop sharing now, and my colleague Sharon is going to talk to you a little bit more about one of the next things. Just trying to work out how to stop sharing.
Just while we're waiting, I just want to remind people that if you have any questions, log them in the Q&A section that is at the bottom of your screen.
Thank you, Sharon.
Thank you. Can everybody see my screen? Okay, thank you. So I'll be presenting this next bit of data on behalf of the co-authors listed here. Okay. So the aim of this analysis was to explore staff perceived feasibility of the Adap CP and adaptations made to accommodate the challenges that staff experienced during implementation of the Adap CP. So multidisciplinary lead teams at each of the 12 services tailored and implemented the Adap CP, and there were two sources of data for this analysis. The first source of data were the staff interviews. A subset of staff at each service purposely selected for diversity were invited to complete an interview prior to implementation at T0, exploring their attitudes and expectations of the Adap CP, and 6 months later at T1 to explore how the Adap CP was working in practice and whether there were any adaptations made and rationales for this. The second source of data were the monthly meetings. Sites allocated to the enhanced study arm met with the Adap team on a monthly basis to discuss and resolve any emerging difficulties. And the Adap team took minutes to capture the discussions and decisions that were made during these meetings. So a total of 177 staff interviews and 84 monthly meetings made up the data for this analysis. And qualitative analyses revealed 6 overarching themes. And where challenges were identified, services made adaptations to the clinical pathway to address them and to optimize implementation success. The first theme was that the Adap CP is of high value. Attitudes towards Adap were positive, and staff perceived that Adap would facilitate early identification of anxiety and/or depression, and hence enable timely care. It would ensure that all patients were identified, even those that did not have visible distress, as seen in this quote here. Because of Adap, we have picked up patients who needed help, even though they didn't appear to need help. And Adap would keep patients positively connected to the service, as noted in the quote below. Adap is seen as a positive way for patients to stay engaged with the team, even after discharge. However, some staff felt that Adap duplicated processes. So a nurse noted, "I think we had a pretty good way of doing it before Adap, but it's good to have a bigger version and it's online so people can do it self-directed." This leads to the second theme. Despite positive attitudes towards Adap, timing for introducing the Adap CP and screening was difficult. While some staff had initially chose to introduce Adap or screen early, this was viewed as overwhelming for patients. So a nurse commented, "I think it's given at the wrong time. They have 1,000 things to think about when they're first seeing the doctors in that situation, so I think that's very inappropriate." And also having multiple entry points into the system made it difficult for staff to routinely introduce Adap to patients. So adaptations included establishing later contact regarding Adap screening, and at one site having backup staff to discuss Adap with patients if that initial contact was missed. The third theme was that online screening is challenging. So despite initial preference for online screening and a perception that it would save time and be convenient for patients, uptake was low, with only 57% of patients who chose email screening actually screening. So staff noted that patients who did not have an email address or lacked access to devices or had low technological literacy were barriers to completing online screening independently. So one of the staff said, "We'd imagine that people would register and then they would screen via emails and electronically, but that hasn't happened." And another staff noted, "We have quite an older population here, so a lot of people don't have email addresses." And also, without staff prompting patients, online screening was quickly forgotten about by patients, as noted in this quote here. "I think having the system online is another barrier. I just think it's so much easier to brush off." In response to low uptake of online screening, some services reverted to in-clinic screening or sent reminders to patients. The fourth theme, a burden too much, was where many staff felt that the Adap tasks were not part of their role. So in this quote here, a nurse noted that their colleague said, "That's not my thing, that's just not my job." And a few staff noted that they lacked the required skills to complete those tasks, or that they just could not fit them on top of their existing stretched workload. So one of the staff said, "With competing demands here of inpatient work and crisis in the clinic, it's been really hard to get those screen ones done as timely as I would like. And I'm hearing that's the same from the care coordinators." To reduce staff burden, some services involved more staff to share the load. Adap roles devolved to a few key staff, and that was usually the champion or the lead team. And so here, one of the lead team said, "There's 5 of us who monitor the alerts. So we each just take one day. And then if an alert comes on in that day, then it's our responsibility to do the triage conversation." And at one service, some of the administrative burdens, such as completing registration slips, were shifted to patients. The fifth theme was no one to refer patients to. So as mentioned earlier, the Adap CP recommends referrals to psychosocial staff for patients with moderate to severe anxiety and or depression. And some services had no or insufficient in-house psychosocial staff, and so relied on referrals to the local GP or private providers. However, there was a perception that these external pathways were not always ideal, or they were difficult for patients to access. But this was the only referral option at some of these services. So here a staff said, "We don't have a psychologist on site. For patients to get a referral to a psychologist, it can be quite a difficult process. Because to get to a psychologist, you need a mental health plan. Or to get a mental health plan, you need a GP appointment. And sometimes that can take up to 3 to 4 weeks." So some services took the initiative to expand referral networks when this was identified as a gap during the tailoring process. So here a nurse said, "Pathways for these patients to go to apart from the social worker are starting to be developed, which is great." And the last theme, micrologistics are key. Many services developed their own processes to avoid workflow breakdowns and ensure that the CP steps were implemented. So this included adding a tick box onto patient files to prompt clinicians to introduce Adapt, placing Adapt registration forms into patient files, or providing a script for staff to use when introducing Adapt to patients. And some of the staff noted that these small micrologistic changes were key to implementation success. So as noted here, and I do think all those little things add up, just makes it easier when you're in the clinic and you're trying to think of 10 things, and this one can just tell you automatically. And while many services adapted the Adap CP, services varied in the degree to which they formally notified the Adapt research staff to update their local workflows, which were created following the tailoring process. So here's an example of the initial workflow, workflow A, and final workflow, workflow B here. And the red indicates where steps have been added to the workflow. So in the initial workflow, this service had only placed the Adapt pamphlets in the induction packs. And in the final workflow, we see that this service has involved a clinic nurse to provide those pamphlets directly to the patients. And the blue arrows indicates where adaptations have been made. So this service noted that sometimes patient email addresses were incorrect, and this meant that patients would not receive the Adapt registration emails to screen. And so they have swapped the order of these steps around by confirming patient contact details first and then registering them onto the portal to ensure that they had the correct email address to register patients to the portal, and so they could then continue on to online screening. So this study demonstrated that health service change is iterative in nature, with staff engaging with, forming views on, and problem-solving adaptations to the Adapt CP to overcome barriers. Feedback by stakeholders to ensure that health service change is sustainable, meaningful, and improves patient outcomes. And thank you. And now I will hand over to Associate Professor Joanne Shaw, who will present the second part of this session, looking at online resources that were developed to support patients and health professionals.
Okay, thanks, Sharon. I'll just... Okay. All right. So I'm going to talk about the online resources that were developed. How well used or useful are they? So I'm going to take you back in time. So when we were developing the clinical pathway, which really started back around 2010, PoCoG, it was before my time, conducted some stakeholder interviews led by Nicole Rankin to explore barriers and enablers to implementing a document such as a clinical pathway. And so Heather and Sharon have really talked about some of the issues around ownership of the pathway, but there were other themes that were identified, such as education and training, resourcing and responsibilities, and also patient reluctance. And that's what I'm going to focus on. So in the qualitative interviews, the multidisciplinary staff reported that staff education and training around anxiety and depression was really important. They needed training in discussing psychosocial issues in cancer, how to use the screening tools, how to understand the Adap CP, and general communication skills training related to dealing with distressed patients. And this really led to the development of the EVIQ anxiety and depression health professional education modules. There was also concerns around psycho-oncology workforce issues. There was this perception that if we screen people, then we're going to have greater numbers of patients identified needing psycho-oncology services, and we just don't have the workforce to accommodate those patients. And there was also a recognition that there is actually patient reluctance to engage with psycho-oncology therapy or psychological therapies in a face-to-face sense. And so to address this barrier, as part of the Adap program, we developed the I Can Adapt online CBT program. So I'm going to sort of focus firstly on the health professional education development and assessments. And really this involved a two-phase process. First of all, we developed the online modules, and then we conducted a pilot study to assess whether or not the online education program improved communication, increased confidence, and was acceptable to health professionals. And then in the second phase, which was implemented as part of the Adapt RCT, we assessed the acceptability and uptake of the education program in routine care in real world practice. So the development of the modules involved an iterative process, and we identified 5 key themes that represented what the needs were that were identified in the qualitative interviews. We developed the content. We had clinical scenarios using simulated nurse-patient interactions to model behaviours. We had self-reflection exercises, and we included clinical perspectives from psycho-oncology health professionals and nurses talking about their experience in approaching these conversations. As I said, we had an iterative development process, lots of stakeholder feedback, and we really were trying to target with these modules both those health professionals new to anxiety and depression discussions, but also more experienced people to give them sort of a refresher of what the key aspects of anxiety and depression and the clinical pathway and screening were about. Having developed the modules, we pilot tested them using a standardized medical simulation model in a pre-post design. So what this looked like was, well, first of all, we asked participants to provide an assessment of their confidence in screening and referral. They then participated in 3 standardized medical simulations with professional actors, and we were able to then assess their communication skills. Having participated in those pre-education simulations, we gave the nurses access to the training, and 3 weeks later, we assessed their communication again using standardized medical simulations, and then asked them to rate both their confidence and the acceptability of the modules, both quantitatively and qualitatively. We recruited 12 oncology nurses from 2 hospitals. And surprisingly, most of the nurses who participated were more experienced than we expected. So when it came to acceptability, overall, there was a positive response to the online training. Participants thought that the content was practical and useful, and the presentation met their needs. And this was reflected in the qualitative interviews, where people said that it was a good mix. Once you get into it, it makes you think about what you do on a daily basis. It was empowering, and it really made you think about how you could do things better. There were some comments, some negative comments, that, although the information was good, the modules, there was actually a lot of content in the modules. We saw improvements in confidence across both identifying anxiety and depression and with the communication tasks of discussing screening, making a referral, and negotiating a reluctant patient to take up a referral. Understandably, that's a really complex task. So even with some training, we saw less confidence with that negotiation. When we looked at the communication pre and post education, we saw across the 3 tasks that there was an increase in communication skills, so objectively assessed communication skills. However, we only saw a statistical significance for making a referral. And I guess we have to be cautious in assessing the statistical significance, given we're talking about 12 nurses here. Interestingly, the increased communication tasks didn't increase the length of consultations, and we saw a decrease for making a referral. So providing skills actually reduced the time or maintain the time that nurses were spending with patients. So the pilot study gave us great hope, and we had great positive responses when we implemented the health professional education as part of the cluster randomized controlled trial. And so when we were assessing acceptability and uptake, we were interested in looking at the ratio of participants who were informed about the training, the number of participants who actually accessed the training and had a bit of a look-see, and those that actually completed training. And we also had some qualitative interviews to explore acceptability and appropriateness of the training across a wider cohort. Unfortunately, uptake was really low. Of the 286 health professionals who were eligible to access the training, only 37 had a look. Of those, 54% actually completed training modules, and most of those that completed training were nurses. When we looked at the page clicks for the training, we confirmed that participants who were accessing the training accessed it on multiple occasions. So training wasn't completed in a single session. And we think that this was really that people were accessing the training on an as-needs basis. So if they thought they had a particularly challenging conversation, they went and had a look at the training. Of those that did complete the training, again, we saw high acceptability. The training was good. It clarified a lot of things, and it helped me work out how to initiate and bring up these issues in conversations. It confirmed and enhanced your knowledge. It was very helpful. However, we did find some barriers to uptake. And this was really around a perception that there was a lack of time to undertake training. Because this training wasn't mandatory, there was a perception that there was an expectation that the training would be done out of hours, and people were really resentful of that. And there was a perception that you really need to have protected time during work hours if this training or any kind of training was going to be effective. There was also a preference for face-to-face training. So we developed online training from the stakeholder interviews at the beginning, but when we actually implemented it, people said, actually, no, we prefer face-to-face. And this was partly due to learning preferences and partly to try and overcome that reluctance to undertake training out of hours. And so I think this quote, the preference of for different methods of learning, protected time, and this expectation to just do it in your own time really impacted on uptake. So in conclusion, with respect to the online training, the training provided strategies and communication skills that did actually improve staff communication and guide conversations in a research context, but we saw really low uptake in the real world. And so there needs to be thoughts around organizational support and incentives to encourage professional development, and a need for potentially a multimodal approach to account for different training preferences. So that's the online training. The next part of the presentation is really looking at the aspects around resources and how we support oncology staff and patients to engage with therapy. And this is the Adapt online program. So Adapt Early is a transdiagnostic, cancer-specific cognitive behavioural therapy program recommended for mild to moderate anxiety and depression. Patients can either be clinician referred or they can self-refer. And the program itself is based on 8 self-directed CBT sessions that are accessed over 16 weeks. The development of the program, as Heather touched on earlier, was in collaboration with CRUFAD, the Centre for Anxiety and Depression Research at St Vincent's and University of New South Wales, and they already had an online program. And so we engaged with stakeholder engagement and consumer reviews in an iterative approach to adapt a general transdiagnostic anxiety and depression program to a cancer-specific version. And so all of the content was very much tailored to the typical presentations that you would see in a cancer context. Again, our research really was was addressed in 2 phases. In the first phase, we evaluated the efficacy of Adapt for anxiety and depression in cancer survivors or cancer patients. And in the second phase, we were interested in uptake of Adapt as part of the cluster RCT of the Adapt clinical pathway. So for the RCT, patients to be eligible needed to have early stage cancer, needed to score above 6 on the HADS, and also have at least 1 diagnosable anxiety and depression disorder based on clinical interview using the DSM criteria. Once consented, patients were randomized to either Adapt or treatment as usual. And the intervention group were given access to the Adapt modules, and they were given access to the modules every 2 weeks. So we controlled access and we assessed anxiety and depression pre and post intervention, as well as a number of secondary outcomes. So we recruited 113 participants. Majority of participants were female. And although we did have a range of cancers, most patients, given the high level of female representation, had breast cancer. Surprisingly, overwhelmingly, the majority of participants were cancer survivors and not in active treatment. That was not what we expected and not necessarily who we were targeting. And most people had been diagnosed 1 to 5 years prior to engagement with the program. The program was actually very effective in reducing both anxiety and depression over the 3-month intervention. And not only did we see overall reduction, we saw a shift over time from more severe anxiety and depression to less severe. So even if patients didn't move from clinical to non-clinical, we still saw a reduction in symptom burden. So we were really positive and thought this is a great program. And so we incorporated it as part of the Adap RCT. And we then assessed uptake and engagement by patients and barriers to uptake through semi-structured interviews with clinicians. So we were able to assess uptake because we have all of the Adap screening data. So we were able to identify eligible participants, and we were able to then see who was actually referred. So referrals, as I said, could have been referred by the oncology staff, and patients could also self-refer. So we could see patient enrollment and lessons completed through the Adap, through the Adapt program. And barriers, we did a barriers and facilitators analysis of semi-structured interviews. So when it came to clinician referral, there were 324 screening events that indicated that participants were eligible for ICANN-ADAPT. Of those 324 events, there were 7 clinician referrals. So only 2% of patients were even referred. And of those that were referred by a clinician, none of them actually took up ICANN-ADAPT. Of the patients who self-referred through the portal, there were 25. However, majority of participants actually had minimal anxiety or depression, and we only had 28% of participants meeting the clinical recommendation of mild to moderate anxiety and depression. Of the 11, only 11 of the 25 self-referred patients completed one module. So again, we had 25 people. Some just went and had a look-see, but actually didn't engage with any of the modules. And of those that did engage with the modules, only 4 were within that recommended clinical range for ICANN-ADAPT. And the mean number of modules completed was 3, although we did have a range from 1 to all 8 modules. When we interviewed the staff and asked them about what they perceived were barriers to both referrals and barriers to patient uptake, they reported that they had a lack of familiarity with the program, they forgot to mention the program, and there were concerns around suitability of patient groups. And I think this was a little bit depressing for us because we had spent time educating and promoting ICANN-ADAPT through the ADAPT RCT, and it was prominently placed on the portal. So a lack of familiarity was we felt a bit deflated by that. Again, patient barriers, perceived barriers for patients was prioritization of physical aspects, a preference for face-to-face. Again, that contradicts the initial concerns around people wanting not to have to go face-to-face for therapy, and this perception that patients are often too well to engage with online programs. So referral uptake and engagement with ICANN-ADAPT early was low and didn't always align with the recommended clinical criteria. What does this mean? There is a need for co-design for online therapy implementation models, involvement of relevant stakeholders, more education for clinicians about the program, better marketing of the program, and training of staff to make effective referrals. Now in ADAPT, we thought that we had done all of these activities, but it seems that it wasn't sufficient. So in summary, with our online resources, despite promising results in a research context, ease of access, all of both the health professional education and the ICANN-ADAPT was available on their portal, and we engaged with stakeholder, we had stakeholder engagement in the development. Uptake of online interventions really didn't translate into meaningful change. And so I think when we're thinking about online programs, there is this perception that if we build it, then they will come. People will use programs if they are given access. But I think moving forward from a research context, we really need to start to finesse who, what, when, and how these programs are best suited to use. So context is everything. And I think this is the next phase of research for online education and online therapy, is really sort of being a more nuanced in how we actually roll these out. So thank you. Okay, so I'm now going to hand over to Mona and the third session when she's going to discuss further the online the RCT and how did implementation play out for staff and services in practice. So over to you, Mona.
All right, thanks, Jo, and hi, everyone.
So in this session, we're going to be talking about how the implementation of the Adap clinical pathway played out both from a staff, patient, and service perspective. So I'm going to kickstart it off by talking about staff perceptions of the clinical pathway. So the first study I'll be presenting on is a mixed method study where we wanted to look at staff perspectives on the acceptability and the appropriateness of the Adap clinical pathway over the 12-month period. And we also wanted to see whether there were any differences in perceptions of acceptability and appropriateness between the two study arms. So staff at each of the services were invited to complete a survey and then to take part in an interview at these 3 time points. And we purposely selected staff to ensure diversity. So the survey that staff completed involved 13 additional study developed items around the acceptability and the appropriateness of the Adap clinical pathway. And the semi-structured telephone interviews aimed to explore the same thing. And these interviews were audio recorded and transcribed. In total, there were 221 surveys completed and 253 interviews conducted by staff over the implementation period. And here are just the characteristics of the interview participant sample, which is also very similar to that of the survey participants. And as you can see, the majority of them were female, over half were employed full-time, and common roles held were nursing and psychosocial. We conducted a factor analysis on the 13 study developed items to assess their latent structure, and we found that 2 factors emerged. The first was perceived benefit of the pathway, which indicated positive acceptability and appropriateness, and perceived burden of the pathway, which indicated negative acceptability and appropriateness. So the scores of the items within each of the factors were summed, with higher scores indicating greater acceptability and appropriateness. And as you can see on the graph here on the green bars, the mean perceived benefit scores were relatively higher compared to the mean perceived burden scores. And we found that there were no significant differences over time or between core and enhanced. The qualitative analysis revealed 4 major themes, and I'll go through each one in just a second. But before I do, it's really important to note that these themes generally remain stable over time, and also there were no differences between the study arms. So the first theme was related to the idea that mental health is an important issue which Adap addresses. Almost all of the staff we interviewed believed that anxiety and depression are common in cancer patients and that addressing mental health is an important part of holistic care. Staff felt reassured that Adap is based very firmly on evidence, and this is a sentiment that was expressed at T0. Staff also felt that Adap helped them identify distressed patients who they may not have otherwise picked up on. But there were some services who believed that their existing psychosocial care processes were sufficient. So this view changed over time for some services, but for others, they remained quite firm in their belief that Adap was just, not necessary for their site. Some staff noted that Adap helped them in the early identification of issues and being able to provide support early on as well for patients. And staff also felt that Adap helped normalize mental health needs as well as help seeking. But there were also some people who thought that Adap is just, not going to be able to overcome the stigma around mental health. The second theme was related to staff believing that Adap helped them to deliver the best care by raising their awareness of psychosocial issues. So they felt that Adap helped to create a whole of team approach. And as you can see in the quote here, we've got one person saying the referral pathways are working. Prior to Adap, I would get contacted and then I would be the one trying to figure out what to do next and who to involve. Staff also felt less stressed when the patients were less stressed. And that's because staff would be informed early on about patients' concerns and would have sufficient time to address those concerns before they escalate. The third theme was that Adap was viewed as fit for purpose. So from a staff perspective, services with an existing psychosocial care pathway, they believe that Adapt easily fitted into their existing workflows. As you can see here, we've got one person saying that it's not going to increase workloads, it's just going to formalize workloads. But for services where this wasn't the case, they felt that implementing Adapt was just going to be too hard. From a patient perspective, staff described how appreciative patients were to participate in the Adapt trial. So although some felt that, you know, for their patients, Adapt may not be suitable for them. So for example, some patients who do not have sufficient English language experience to complete the screening, they weren't able to be included in this, you know, in the Adapt trial. And the last theme was that Adapt was viewed as a catalyst for change. So some viewed Adapt will provide them with more information and data about patient needs. As one person stated here, Adapt will give them a better idea of how many people are actually needing a psychologist assessment so that they can make a case to have a psychologist at their service. Adapt was also seen as a way to improve multidisciplinary communication, as well as improving existing referral processes. Staff also commented that Adapt prompted services to explore new referral pathways that they may not have otherwise thought of prior to Adapt. So in conclusion, there appears to be a high perceived acceptability and appropriateness of the Adapt clinical pathway. There were, however, some concerns around the impact on workload, that Adapt may not be suitable to their patient population, or that they perceived the Adapt as being unnecessary, particularly in settings where psychosocial care was already in place. And despite the fact that enhanced sites were provided with additional support during the implementation period, this didn't actually impact perceived acceptability or appropriateness because we found no differences between the study arms. And this was apparent in both the quantitative and the qualitative data. And if you'd like to read a little bit more about this, I encourage you to have a look at our recently published paper in BMC Health Services Research. Now I'm just going to be switching focus and now be reporting on findings based on the screening that patients complete while they were enrolled in the Adap trial. So just to provide a little bit of context, we had over 1,300 screening events and 696 patients across the 12 services during the implementation period. 26% of the patients completed the screening only once, and 74 completed screening 2 or more times. And as you can see in the table in the middle of the slide here, 70% of screening events were of minimal anxiety or depression. And just some demographics of the patients who did screen. The mean age was 63 years. Over half of them were female, and the most common cancer diagnoses were breast and gastrointestinal cancers. So what we were interested in is we wanted to look at the changes in distress and the number and types of problems reported by these patients during the implementation of the Adap trial. So we analysed data from the very first time that patients complete the screening, as well as any other rescreening that they then went on to complete. And as mentioned in the earlier presentation, services had the option of choosing between one of 2 screening tools. And because 10 out of the 12 services opted to use the distress thermometer and the problem list, that's the data that I'll be focusing on for the talk today. So for those who aren't familiar with the distress thermometer, basically patients need to indicate how distressed they're feeling on a scale between 0, no distress, to 10, extreme distress. And then they are presented with a list of 39 items or areas where distress is likely to occur. And these are organized according to 5 categories or domains, those being practical, social or family, emotional, spiritual or religious, and physical. Patients screened either in clinic or via email approximately every 3 months. We also collected information such as age, gender, cancer stage, and time since diagnosis. So in total for those 10 services, we had over 1,200 screening events. And what we did was we grouped those screening events into 3-month blocks based on which quarter during the implementation period that they were completed. And then the screening events within each quarter, we further differentiated them based on whether they were an initial screening or a subsequent or follow-up screening. So when we controlled for demographic and clinical factors, we found that there was a significant reduction in distress from initial to subsequent screens. We also found that younger people tended to report higher levels of distress than older people. And we also saw a reduction in distress at 6 to 12 months since diagnosis. And now looking at the various domains, so over 8,000 problems were reported. And as you can see on the graph here, on the orange and the green bars, on average, there were more emotional and physical problems indicated than practical and social. So we found that there was a significant decrease in the average number of emotional, physical, practical, and social problems reported from initial to subsequent screens. We also found that younger ages tended to report, on average, more emotional, practical, and social problems. And we saw an increase in the number of physical problems at the 3 to 6 months since diagnosis. This table here gives you an idea of the most commonly indicated problems for each of the domains across the 4 quarters. And as you can see for the practical domain, the most commonly indicated issues were those relating to finances or insurance, as well as treatment decisions. In the social domain, the most consistently indicated and commonly indicated concern was that around the health of family members. In the emotional domain, there was a high prevalence of worry, and we see that indicated as, once again, in each of the 4 quarters. In terms of the physical issues, the most common were those relating to issues with sleep as well as fatigue. And these are actually very consistent with what we see in prior research as well. This graph here displays the proportion of problems by screening occasion. So while some problems such as fatigue or worry, as you can see here, are quite high, what we do see is that there's a trend for a decrease in the recording of those problems from initial to subsequent. So just to conclude, these results really highlight the value of repeat screenings. So the initial screen allows patients to flag, areas of concern, and rescreening allows patients to indicate new or persistent problems, as well as giving healthcare professionals an opportunity to monitor and assess needs. There was a high number of emotional and physical problems reported, but what I really want to make a note of is, while emotional problems are common in patients with cancer, it's really important that these patients are provided with support to help alleviate those emotional concerns and to help ensure that there's a reduced risk of them going on to develop clinical levels of mood disorders. We also found that the types of problems that patients report are quite persistent over time. So this indicates that some problems may be more difficult to manage than others, or that access to or implementation of evidence-based interventions may not be widespread. So that's it from me, but now I'm going to pass on to my colleague Sabina, who's going to be talking about clinical levels of anxiety and depression and how staff approach those.
Thanks very much, Mona. So I will be talking about the service's response to clinical levels of anxiety and depression among patients completing regular screening over the course of 1 year. So as the theoretical background has already been provided in previous presentations, I will jump straight into our research questions. So in the study, we were interested to find out the proportion of screening events that triggered the Hospital Anxiety and Depression Scale, or HADS for short. We also wanted to find out how many screening events scored in the clinical ranges of anxiety and depression and how these scores changed over time. And importantly, we were interested in finding out how the services responded to the clinical levels of anxiety or depression of cancer patients. So in short, we aim to explore changes in the anxiety and depression scores among patients over time, and to describe the referrals made for clinical anxiety and depression. So the analysis is currently ongoing. So today I will present some of our preliminary results from this study. The 12 sites in the clinical pathway could choose between 2 screening tools. So the 10 sites chose that this stress thermometer, where a score of 4 or above triggered HADS, and 413 screening events completed the HADS measure. And 2 sites chose the Edmonton Symptom Assessment System as a screening tool. And on ESAS, there were 2 screening items, depression and anxiety. So for depression, a score of 2 or above triggered HADS, or for anxiety, a score of 3 or above triggered HADS. And in total, 40 screening events completed HADS after ESAS. In total, 453 HADS were completed, which is about a third from the total screening events. And we compared the sociodemographic data of the total number of screening events and the subsample who completed HADS. And there were no differences between the 2 samples, apart from the HADS subsample being slightly younger compared to the total sample. So on the left-hand side of the table, we can see the cutoff scores for HADS. So 0 to 7 refers to a normal score on the anxiety or depression. 8 to 10 refers to moderate score, and 11 to 21 to severe anxiety or depression. And we can see that about 55% of the samples scored in the clinical ranges of anxiety and about 35% in the clinical ranges of depression. And on the right-hand side of the table, we have the mean scores of anxiety and depression in 4 quarters, which Mona has already explained. So over the course of 1 year, the mean scores for both anxiety and depression remained relatively similar and stable, and there were no statistically significant differences between the mean scores over time. In terms of the referrals, we collected information on whether referrals were discussed with the clinical team and whether a new referral was made, which can be seen at the bottom of the screen or bottom charts. And we also collected information where if patients already had an existing referral or whether they had refused treatment when it was offered to them, and that can be seen in the middle. We also collected data for referrals that were not offered. So that means that the discussion with the clinical team didn't occur at all. And so for anxiety, we can see that majority of referrals were made for the severe scores of anxiety. And for depression, we can see that majority of new referrals were made for the moderate scores of depression. And there were also a number of patients that had already existing referrals, or they had refused a referral when it was offered to them. We then looked at the proportion of new referrals made in each of the 4 quarters using the maximum clinical score of either anxiety or depression. And we can see that there has been an increase from quarter 1 to quarter 2, but the proportion of people with new referrals remained relatively similar over time, and this slight increase was not statistically significant. And in the table below, we can see that when referrals were discussed with the patient, there were more new referrals made compared to patients having an existing referral or patients refusing treatment. On this slide, we can see the psychosocial referrals for anxiety in green and for depression in orange. And most new referrals were made for social work or counseling, particularly for lower HADS scores. And we can also see that several referrals were made for psychology and psychiatry for patients experiencing either mild, moderate, or severe levels of anxiety and depression. And here for psychiatry, we can see that referrals were also made for low levels of depression. And that could be due to the fact that 2 services didn't have a psychologist on site, like Sharon mentioned before. So they could only access a psychiatrist, and that could explain the numbers of referrals here. So in conclusion, nearly 1/3 of all of the screening events had triggered HADS, and of these 55% were in the clinical ranges of anxiety and 35% in the clinical ranges of depression. However, over time, the mean scores of anxiety and depression remained relatively stable. Of all the new referrals that were made, 61% were for the clinical levels of anxiety and 44% for the clinical levels of depression. And the highest proportion of referrals were made for social work or counseling, as well as for psychology and psychiatry. And we can see that the percentages for anxiety and depression are quite similar. So the key message from my presentation is that regular screening did identify potential clinical levels of anxiety and depression, and that services were able to respond according to the referral pathway that was available to them. Thank you very much, and I will pass on to Jo, who will introduce Jackie. Thank you.
Thanks, Sabina. So sort of changing up a little bit here at the moment as we move forward. So I'd like to introduce Jackie Yim. And Jackie has just completed his PhD on the Adap program, and he's going to discuss the health economic implications of Adapt and anxiety and depression. Over to you, Jackie.
Great. Can you see my screen?
Yes, we can.
Yeah. Okay, great. So hi, everyone. I'm Jackie, and thanks for the opportunity for me to come and present some of the work that I've done, my PhD. So I'm going to be presenting 2 studies that I completed. The first one looking at the costs and consequences of implementing the Adapt clinical pathway, and then the second study looking at health service use in the Adapt cohort. And then I'll wrap things up with some implications for health services. So study 1 looking at cost and consequences of the Adapt CP. So the objectives of the study were to describe the costs of the implementation of the Adapt CP, and then also the costs of running the Adapt CP in clinical practice, and then to examine the costs and consequences of implementing the Adap CP, and the results will inform policymakers of the resources required to implement the Adap CP into routine care. So for the costing, a health service perspective was taken and a bottom-up approach was used because I had detailed records, access to the detailed records of all the tasks conducted and the persons involved. So I had access to contact logs, planned and ad hoc, which included things like emails, phone calls, and meetings. I also had access to meeting minutes, which were also used to supplement the contact logs where information was missing. And I estimated the labour costs and salaries using New South Wales Health Awards and the Adapt RCT budget. A bottom-up approach was also used because each site had different health professionals assigned to each task. So for example, most sites assigned a nurse to conduct the screening, but some assigned a psychologist. And so a bottom-up approach was able to capture the nuances of clinical practice at each site, and costing was done in Microsoft Excel. So cost consequence analysis was conducted, and adherence was originally planned to be used as a measure of consequence, but at the time of the study it was unavailable because COVID-19 had prevented on-site data collection. So I ended up looking at the cost per patient and the cost per screening event. And when I talk about a cost consequence analysis, it essentially is presenting the measurement of cost, which would be monetary units per the measurement of outcomes, which could be single or multiple outcomes, health and non-health related, expressed in actual units. And when I talk about a screening event, that is when a patient is screened with a screening tool, and screening at regular intervals is recommended by the Adap CP. And so we can look at screening events as a proxy measure for adherence. So you would have seen this before, but just a quick recap. Across the 12 participating sites, some sites included all tumour streams, whereas some did not. And this was also the same for the number of departments involved. So you can see here some involved only 1, right up to 3 or 4 departments. So across all the sites, the average number of participating patients was 61 patients, and the average number of screening events was 109. I'm sure you're all familiar with this. This is the implementation process, but I just wanted to highlight that at this point, after the go live week, is when the Adap CP was used in routine clinical practice. And from there on, that was where the core and enhanced sites started to differ. So this table presents the cost of implementation at each site. So for the core sites, the average cost of implementation was around $9,000. And for the enhanced sites, the average cost of implementation was around $11,200. And the overall average cost of implementation is $10,000 around. This is the in-clinical practice process. I'm sure you're all very familiar with this. And so this table presents the cost of the Adap CP in clinical practice. So for the core sites, the average cost of running the Adap CP in clinical practice was around $16,000. And for the enhanced sites, the average cost of running the Adap CP in clinical practice was around $3,000. The large difference that you see here in costs is due to because the core sites had actually saw more patients through the Adapt program, whereas the enhanced sites had less patients going through the Adapt program. And the overall average cost of running the Adapt CP in clinical practice in the first year was $7,700 roughly. So for the cost per patient and cost per screening event. So for the cost per patient, for the cost of implementation, as expected per patient, enhanced sites are more expensive in the first year due to a more involved implementation process, and that explains the large difference in costs that you can see here. The cost in clinical practice per patient is similar between core and enhanced sites. And for the total annual cost of the Adap CP in the first year, as expected, enhanced sites are more expensive due to a more intensive implementation process. For the cost per screening event, again as expected, enhanced sites are more costly for implementation costs per screening event. And for in-clinical practice cost per screening event, costs between core and enhanced sites are similar. And enhanced sites are more expensive for the total annual cost for the Adap CP in the first year. So this graph presents the average cost per patient at each clinical site. Here you can see orange is the core sites, blue is the enhanced sites, the triangle are small sites, and circles are the large sites. And so what we can see here is that the more patients enrolled in the program, the less it costs per patient. And so we can see here that around 70 patients, we can see that the cost per patient starts to plateau, indicating that sites should aim to have around 70 patients to ensure the implementation effort presents best value for money. So this table presents a 5-year cost projection for a health service that may decide to fund the Adap CP program. And the costs presented here are based on an average cost of core and enhanced sites, and on an average of 61 patients seen a year. The assumption made here was that a simpler implementation process would occur every 2 years as a refresher training for all staff. So you can see that at years 3 and 5, the implementation costs are halved of year 1. And over a 5-year period, the Adap CP is projected to cost around $59,000. So one of the strengths of this study is the use of the Adapt RCT to estimate costs. So the costs presented here are realistic and accurate. And we saw that the enhanced sites cost more, but there is potentially increased adherence, but was unavailable at the time of this study. And this study highlights the importance of maximizing patient participation in new health interventions, whereby the more participating patients there are, the less cost it is per patient, leading to more value for money. And so compared to the enhanced implementation strategy, the core strategy is less costly and produces similar consequences in the first year. Cost per patient and per screening event in subsequent years is similar. So on to study 2, looking at health service utilization in the Adap cohort. So the objective of this study was to observe whether health service utilization changes over time after enrolling into the Adap program 6 months before and 6 months after. And the results will inform policymakers of the patterns of health service use after enrolling into the Adap program. So the Adap sample are people who have a diagnosis of cancer, have been registered into the Adap program for screening for anxiety and depression, and may or may not have anxiety and depression depending on the screening score. And so there are some sources of confounding here, and so we can't claim causality. The first one being the timing of enrollment into the Adap program, which is not independent of their cancer diagnosis, and cancer treatment, which may impact on both anxiety and depression and on health service utilization. And the second one being that cancer treatment received, which is health service utilization in itself, which will be affected by cancer staging and time since diagnosis. The role of the Adap program is to commence screening, which may lead to treatment if needed. And so we can look at the Adap program as a quasi-intervention, where enrolling into the Adap program marks what might be a change in health service utilization. So an interrupted time series approach was taken to observe changes in health services utilization before and after enrollment into the Adap program. And a negative binomial regression model was used, which allows for changes in trend over time after enrollment into the Adap program. This is a graphical representation of the regression output. The red dotted line here symbolizes the date of enrollment into the Adap program. Beta represents the trend in health service use before enrollment into the Adap program, and gamma represents the trend in health service use after enrollment into the Adapt program. So after excluding those who did not consent for Adapt and the use of their MBS and PBS data, we're left with 424 patients for the MBS dataset and 275 for the PBS dataset. Overall, the characteristics of those who consented are similar to those who did not. There are more males in the MBS dataset compared to the PBS dataset. And as to be expected, most of the sample consisted of those above the age of 55, which is consistent with the cancer population. Majority of the sample were diagnosed with cancer less than 1 year at the time of registration into the Adap program. Sorry, that's a little bit off-centered there. And the proportion of patients allocated into each step was consistent with the Adap team's expectations and is consistent with the proportions presented into clinical practice, where, sorry, this is a bit off-centered, but where majority screened as step 1, which is patients without anxiety and depression. And onto the results, just looking at the MBS items, medical services. So this table presents the mean number of MBS services used before and after enrolling into the Adap program. And on average, there are more MBS services used after enrolling into the Adap program, except for GP services. So you can see here for all MBS services, before enrolling is 9.7 and after is 11.6. Specialist and non-GP services, 3 and 4.7. Diagnostic and pathology services, 5.4 and 5.8. So this is the regression results of the use of MBS services before and after enrolling into the Adap program. So here we can see that the trend in MBS service use was increasing per month before enrolling into the Adap program. And this increased at a rate of 24.1% per patient in each month. And after enrolling into the Adap program, the trend in MBS service use decreased at a rate of 27% per patient in each month. And onto PBS items, which is medications. So this table presents the mean number of PBS items used before and after enrolling into the Adap program. So you can see before enrollment is 3.3 for all PBS items, and after is 4.6. And we also looked at a group of mental health related medications. So before was 0.5 and after was 0.6. So this is the regression results of the use of PBS items before and after enrolling into the Adap program. So similar to the MBS services, before enrolling into the Adap program, there is an increasing trend in the use of PBS items per month, and that increased at a rate of 9.9% per patient in each month. And after enrollment, the trend in utilization decreased at a rate of 26% per patient in each month. But more interestingly, for the use of mental health related items, we can see that the trend the trend in health service utilization before enrollment into the Adapt program was increasing at a rate of 12.7% per patient in each month. And after enrollment, the trend in utilization decreased at 15% per patient in each month. And so a strength of this study was the use of MBS and PBS data to quantify health service utilization. And we saw that there was a decrease in utilization of health services, but that cannot be fully attributable to the Adapt program. And so hence caution must be taken to interpret the results presented in the study. So the trend in utilization of health services increased over time, and after registration into the Adapt program, the trend in health service utilization decreased, resulting to less cost to the health system. So just some implications for health services. So for the first study, looking at the costs and consequences of implementing the Adap CP, I think the implications here for health services is that it's really important to maximize patient participation in new health interventions. As we saw, the more participating patients there are, the less cost it is per patient, which leads to more value for money. And we saw that that was around at the 70 patient mark. For the second study, I think the implications for health services here is that we know that anxiety and depression is treatable, and once identified in cancer patients should be managed to alleviate the psychiatric burden and potentially reduce costs to both patients and the health system. And we, in this study, not presented today, we also looked at patient out-of-pocket costs for MBS and PBS services, and we saw those costs also decreasing. Other papers that came out of the PhD were these, and they informed the development of the studies presented here today. I thought these might be of interest. I think in particular, this one would be really interesting about patient preferences for anxiety and depression screening in cancer care. Just want to acknowledge that this research is supported by an Australian government research training program, but also by New South Wales Health PhD Scholarship and the Adap Top-Up Scholarships. I really want to thank my supervisors, Professor Rosalie Viney, Associate Professor Joe Shaw, and Dr. Shane Aurora. A huge thanks to the Adapt RCT staff, specifically Dr. Heather Shepherd, Dr. Mona Faris, and Miss Jessica Cuddy, and also the SHARE staff and PhD group. And thanks for listening.
Thank you very much, Jackie. That was a really interesting and in-depth exploration of all the MBS and PBS issues related to the Adap program. So that's fantastic. Thank you very much for sharing those things. Maybe if you could stay on. So before we go on to the last section, what we thought we might do is just respond to some of the questions that we've had coming up in the Q&A. So I'm wondering whether we should start, I don't know whether we should start with the question that's just come in from Ben. And thank you, Ben, for your questions, just in relation to your presentation, Jackie. So sorry to put you on the spot there. But Ben was just asking, and it might just be that whether you could just re-explain this for us in the audience. Why were the mean service use levels higher after Adapt, but the trend decreasing? That was.
Yep. So I think we would have expected that people used more health services after enrollment into the Adapt program. That's because I think most people who enroll into the Adap program are, I guess, newly diagnosed cancer patients or just freshly registered into the cancer service. And so they are probably having radiotherapy, they're having chemotherapy, they're having all sorts of medical services relating to the cancer. But I guess in terms of seeing the trend over the next 6 months, why that would be decreasing is because I think once their cancer treatments are over, once they've had the immediate cancer sort of treatments and medications received, you should expect to see once they leave the cancer service that their utilization should decrease over time. Yeah.
Great. Thanks very much, Jackie. Hopefully that answers Ben's question and others from the audience as well. So we've had a couple of other little questions that some of us, the Adapt team, have been answering, has been going through, but there was a few questions, Joe, in relation to some of the online therapies and online education. Wondering whether you've had a chance to see those questions, Joe, whether you had any kind of comments or thoughts around the issue of the hybrid training model in relation to EverQ, as well as in relation to kind of how the issue of self-referral into the ICANN Adapt program as well. Thanks, Joe.
Yes, the hybrid model. I think that from our qualitative interviews, people were saying that they like the face-to-face, and maybe they could do some background reading or do some background work in sort of to plan and to in preparation. That's the word, preparation for the training. I'm still a little bit skeptical whether or not the hybrid model would work. I think that if we're asking people to do online training out of hours, the likelihood of busy clinicians doing it is quite low, because this is not a mandatory education. I think that using some sort of video in a face-to-face training session would probably be the option that would be most preferable. I think the other thing to think about is that people say they want face-to-face, but when you try and run face-to-face training, because of staffing and resourcing issues, often people register and then are unable to attend. So I think it's the real challenge of how you actually involve people and train people in kind of the soft skills of cancer care. With respect to referral to Adapt, ideally, so the original model that we proposed was clinician referral. We did put the self-referral, we put Adapt into the patient resources for self-referral as a sort of an option B if people felt that they didn't want their cancer team to know that they were accessing psychological services. I think that based on the CRUFAD model and similar models where the online resources are online and accessible online, or should I say sort of in the public domain, there still, I think, needs to be some clinician oversight. And so if the CRUFAD model actually insists that if people access via Google and they register, they do need to provide a GP contact. So I don't think that because we're talking here about a therapeutic program, not a psychoeducational program, I think that full self-referral and self-management is probably not the way to go. I think it's very hard for patients with anxiety and depression to self-motivate to complete purely self-directed programs. So I think we need to find a way to integrate online into referral networks within the health system, within the cancer system. And we haven't quite got the model right with Adapt, I suspect.
And any golden nuggets in addition to encourage or support health professionals to access training resources?
This is the million-dollar question. I think that in terms of communication and communication around emotional concerns, I really do think that we need to find a way to ensure that clinicians see the value of communication around emotional concerns has the same weight as discussing physical concerns. I think that there is still a perception that anxiety and depression are important, but there's always a prioritizing of physical concerns. And so I wish I had the answer. I think this is a real challenge for communication skills training more broadly. Incentivizing is something that our participants suggested might have engaged them more. And I think it's really this organizational priorities. If organizations are really serious about wanting to address emotional concerns, then they actually have to give their staff protected time to be able to engage with online training or any kind of training. And I think that's really the bottom line, is that we need to take a systems approach as well as a values-based approach with individual clinicians.
Thank you, Jo. Now, there's just a couple of questions, and Tim and Ben are kind of jumping ahead of us with asking us around adherence to the clinical pathway itself and some more information around our implementation strategies and the outcomes related to the core and enhanced arms. So I guess to say, watch this space. This is things we're looking at. We have a measure of adherence to the clinical pathway that we will be using to actually look, and that's our main outcome for the cluster randomized controlled trial. So watch this space. We'll see, and then hopefully we'll be able to make some recommendations in relation to those different suites and levels of support for services to prepare and sustain implementation that we saw within our trial through the 12-month period and beyond. So watch this space, but we'll let you know once we know. Thanks very much. So what I'm going to do for the last little bit is just go on to our last section, which I'm hoping you can see once I hit the right button. There we go. I'm hoping that's showing the right thing now. Somebody say yes to me, please.
Yes.
Good, thank you. Okay, all right, so where are we at now? So we've had a bit of a, I guess, a look through some of the aspects of preparing services for implementation, looking at the resources for staff and patients, and then looking at how it played out within those 12 months in some aspects of our research. And our goal was to support services to implement the Adap clinical pathway into practice, but also to investigate from an implementation perspective what works and what doesn't. And as this image shows, we never expected it to be a straight line. We expected the odd curveball, but the reality is that many of our experiences along the way have been a lot more like the lower of these two lines on this slide. We know that healthcare and health services are complex. Throw in staff and patients and a pandemic, and the adaptations and responsiveness become really key, much like most implementation theories and frameworks, much like those implementation theories and frameworks outline in all of those. That the context, as Jo said earlier in her presentation, context is so important. So being able to adapt and respond was absolutely key in the work that we did. So at the end of the 12-month supported implementation that we had within our trial, we were actually able to allow some services to continue using the Adap portal and therefore implementation of the Adap clinical pathway, while services that had commenced their 12 months implementation period later. So some services in the enhanced arm of the study had been proactively pushed to discuss issues of sustainability along the way in this regard, but all services were asked at the 9-month mark what they wanted to do. And you can see here on the slide here that 6 of the 12 services continued to use the Adap clinical pathway using the resources provided by the programme beyond their 12-month period, and 1 service additionally just kept access to the resources but did not continue to screen using the portal. So we were very, I guess, pleased about that uptake beyond the 12 months for those services, that we could do that. And we could do that within obviously, as we were within our funding timeline. Sorry. Okay, sorry. Understanding and adapting to context, as I said, were constant themes across our research. And we had, there was the appetite and push to incorporate patient-reported measures, was strong and is strong in cancer care and across healthcare services more broadly. And this was illustrated by the upcoming launch of the ACI Hope platform and the Cancer Institute New South Wales patient-reported measures platform, which learnt from some of the learnings from Adapt, as well as the prompt care program out in Southwest Sydney LHD. And we certainly saw, a willingness in services to implement patient-reported measures, but there were, and I guess what we kind of were aware of in this patient-reported measures environment, that there is a number of measures being used across services and in tumour-specific contexts. And what we kind of feel, and see that there is maybe a need for a coherent approach, as patients, rarely interact only with one service. Sorry, just having some issues with my slides here. So one of the things that obviously happened was as the Adap was rolling out was that, as it came to the end of the 12 months, some services, they suggested they cease using Adapt once the study period ends, because they're expecting the PROMS program to be rolled out next year and wanted to wait and be prepared to embed that into their workflow as well. In terms of service redesign, in response to COVID, this obviously impacted some of our participating services in ways that are of no surprise to many of you. And the Adap clinical pathway, potentially may even have more value in identifying and responding to the emotional burden of cancer and the last 2 years' experience for all of us. Deciding, I guess, when other things that happened was infrastructure and new buildings that happened. So deciding when to start the Adap clinical pathway implementation for some of our services and juggling planned and actual rebuild dates was interesting, to say the least. Wi-Fi network access and 2 thick walls were one challenging example with one of our services. And we also, I guess, in understanding and adapting to context, we, recognize that, the Adap portal was provided in English, and we need to be able to address, inclusivity and diversity to avoid, inadvertently exacerbating existing health inequalities between those with higher and lower literacy skills. So we wanted to, I guess, one of the things that we're looking forward to is, to, work towards, making patient-reported measures more accessible, as well as having accessible online information to support the pathway and all those resources in the future as well. So what we have learned, taking into account all the things we've learned and all the information we have and are continuing to share from our research, there's always so much that we can build on. We gain staff perspectives from interviews, surveys and meetings, highlighting the need for researchers and health services to work collaboratively, make time for the small but those critical micro-logistics, needing to make sure that we allow time and ensure the right people are involved at the beginning and throughout to sustain and tweak as you go. And not forgetting to plan and measure staff and service level variables in intervention and implementation studies as you go. These things are really important to, take the temperature, to check with the context and check with, the culture of the services that everything is still working and fitting. As Jo showed us, our online resources for patients and staff, despite those promising results in the research context, did not translate to meaningful change. And we need to think about how services can facilitate that training access within work time and how maybe blended models can meet, for patients can actually meet therapeutic engagement. What we did show, what we feel we showed, that we showed value in repeated routine screening, both in identifying and responding to patient concerns and potentially reducing overall health system costs. So these were some of those things that we saw. But I guess one of the things that is that, adequate resourcing and high level commitment are really key. So our take home messages for the last 12 months are really that it's the small things that count. These things are, those small things that make the difference. Sorry, I'm having. And that tailoring as you go, and having in mind that an iterative ongoing process is absolutely part of the recipe for implementation. That, as you will have seen, I mentioned a couple of times, that context and culture are so important in implementation and was so important in all the services, paying attention to that in all the services that we worked with, and being able to kind of adapt and change and be flexible with implementation in terms of interventions as well as in terms of implementation strategies. But what our take home message as well is that this clinical pathway approach to anxiety and depression can reduce patient emotional needs. And we hope that we're able to demonstrate that. We've been able to demonstrate what the work that we've done has had an impact there. So then we just wanted to open it up to you and see whether there's any other questions from the floor. And I'm not sure whether I can see any more. And I've lost people on the screen. So. Any other questions coming through?
No, people are a little shy. No questions?
No questions.
Oh, okay. So I guess I could ask a question. As a research team, is there anything that, looking back in the development work, in the rolling out, anything that you would have done differently?
Gosh, that's a really hard one. I don't know. There's always, I guess there's always, I don't know. I don't know that there's one particular thing, because the reality was that, obviously I had the privilege of working with all 12 services. I think and every service was a little bit different. So I think the more, maybe building more flexibility into it, but we had some things that were flexible, but we also, it's also important to have a structure as well to work things up. I think maybe, I guess what I would potentially think is that having a lead team or a team at the service and encouraging them to meet regularly and having a forum for where services could discuss service change was something that I guess that might be something that I would support. But I'm not sure that I could necessarily think of one or two things that we would do differently. Maybe others from the team would, or Jo, you have any thoughts about that?
No, I don't have any thoughts.
Sure.
Do you want to just stop sharing your screen, Heather?
Oh, Well, I mean, I've got a few more slides just to talk about where we're going in the future. Okay. So maybe I'll go on to those because there's a couple of questions coming up. I can see that from Malana and from Diane. So what I might do is go on to what we're doing next. So what we're doing next. So obviously this work has been happening since 2015. And as I said, there's a few things obviously that we were aware of as we went along. And we've been lucky enough to kind of go on to do some other collaborative work. So we are looking at the issue of universally accessible patient-reported measures, and we've got some work going looking at developing a pictogram version to address both cultural and linguistic, diversity as well as low literacy. And we're looking at, we've started some work looking at developing the ESAS-R into images to address that issue, and we're currently piloting that work at the moment. We've also been involved in developing and building on the Adap portal and adding in physical symptom alerts and triaging those issues alongside the alerts for anxiety and depression within our portal, and we've done that with work with Flinders Hospital in South Australia. We're also about to start a collaboration with, well, we have started really with Ramsay Healthcare Services to look at developing the Adap clinical pathway as part of Ramsay Health Cancer Services. And we're also going to be adapting Adapt for patients with brain cancer as part of a large trial with an intertrial group consortium with PoCoG and Cogno as well. So that's some other work that's going on now. So final thoughts and thanks, I guess, is the other things I guess wanted to share with you, because there's a lot of work and we've presented a lot of things today, and there will be more findings being presented and published over the next little while as well. So as part of this program of work, we also were able to, through our funding through Cancer Institute New South Wales and the TPG, we were able to support 3 PhD students, and you've seen Jackie Yim presenting today. But we've also had one PhD completed with, which was Dr. Michael Murphy, looking at I Can Adapt, the online psychological therapy in cancer care, and then Elizabeth Geerligs, who has her PhD is currently being reviewed, looking at organisational readiness for implementation. And Jackie Yims as well, his PhD is completed and is under review right now as well. So these have been really great things for us to see, and obviously building research careers of other researchers as well. Much of the work that we've presented today, we have actually published. So we have a whole suite of Adapt program publications, and there's a large list here of our development and pilot work, and then work in our online therapy related to our development of I Can Adapt Early and piloting and the uptake of that, as well as our online EverQ program, which is just under revisions at the moment. And we're just beginning to get a number of publications from our cluster randomized controlled trial as well. So all of these, the ones that are published, you can see there, and they're all available via the link on the PoCoG website, and you can see that link there as well. I guess one of the last things to mention, and a kind of thank you to everybody. I think I said at the beginning, but maybe I didn't. But this work, in terms of implementation, working with services, this kind of work does take a village. And certainly for the Adap program itself, the Adap staff team and the 22 investigators of this large program, it really has taken a village. And we've been working on this when we got the funding from 2015, but I assure you there were 2 or 3 years of work prior to that in getting the funding to do this. So I just wanted to shout out to all the people that have been involved with this program of work, to all the research officers and research associates that have worked with us, and all the investigators around the world and across New South Wales. Thank you very much for all your help. And of course, we definitely need to pay a big thank you to the 12 cancer services who put their hands up, participated in the trial, and their staff who participated in all the interviews, completed the surveys, and their patients who participated in the trial by completing the screening regularly and engaging with the Adap portal as well. So this is really, this program of work has really added to the growing implementation science literature in psycho-oncology practice and research. So we look forward to sharing more with you, but a big thank you to all of those people.
Okay, thank you, Heather.
Thank you.
There's just a few questions that we could address. So Alana asks, the resources and referral pathways, were they identified only before you went live in the stakeholder meetings or also throughout the trial?
So I guess within the engagement meetings prior to the setting up of the pathway, its implementation, we obviously identified ones, and that was a great exercise for a lot of the services that hadn't kind of formalized some of those pathways and options that they had available. But certainly within the 12 months, services may be refined or added to services that they had or options that they had. I think as Mona alluded to, or even Sharon alluded to, in kind of adapting some of those adaptations that were made, certainly there. And of course, we're able to kind of change things as they went through. So that certainly was, and I guess that's part of that iterative process in a program like this, having people who can take ownership of that and update those things, but also making, I guess, making sure those things were current as well. It's really important in this idea.
Okay, there's a couple of questions specifically about, is there a plan for any further rollout into clinical settings? And is there anything happening in the ACT?
I don't know whether I can answer about the ACT. I mean, I think in terms of rollout into other clinical settings, as I said, there is obviously a push for, I mean, the Adapt program has very much been, I guess, promoting the idea of the whole pathway approach, patient-reported measures, building on, that are added to by referral pathways, and making sure that people don't fall through the gaps, and having referrals and checkups and then rescreening. But certainly, as I said, the patient-reported measures agenda and stuff is very much out there, and there are more and more initiatives happening both across general hospital care here within New South Wales and more broadly. But I think, Jo, you've maybe got more of a take on wider states, but certainly patient-reported measures are happening in many aspects of cancer care across Australia. So I would think that there would be an ACT, but I don't know specifically to answer that question from Sarah.
Yes, I'm not sure about ACT either. But as you say, there is a push nationally for patient-reported outcomes, and the screening for anxiety or just screening for distress is part of the Cancer Australia national framework. So I think if it isn't on the agenda in some of the states and territories, it will definitely be on the agenda in the next little while, because it is going to be something that cancer services are going to have to report to the state, to report nationally on their screening activities. And Diana has a second question: is Adapt available for use in clinical settings? Yes, this is the million. Yes, we're still trying to work out how we're going to manage this. So Adapt was actually, we had a central clinician model. So we had a clinician, a psychologist who we employed on the Adap program for to oversee Adapt. And Adapt is actually still available through CRUFAD. They have elected to keep using Adapt, and we're now, as an organisation, trying to work out how we can make Adapt available without having, how do we actually transfer it to the local setting, and what that model would look like. Given the low uptake, we haven't necessarily prioritised rolling it out in its current form, and so we're doing some more work to see whether there are other tweaks to either Adapt or to the model of delivery that will enhance uptake in real world settings. So at the moment, it's a watch this space.
Absolutely.
Any other questions?
Yeah, I just see Diane just agreeing that current reliance on telehealth, I can see real value in the digital format of PROMs and the Adap model. Yeah.
Yes, we have tried to sell it to Victoria. We have tried to discuss it with Victoria, not sell.
Yeah.
We're not looking to make money on it.
Yeah.
But you know, so far none of the Victorian services, yes, have actually they're interested, but no one has actually taken it up. So yeah. we're still hoping that the Adap model will actually, it has a national relevance. So we're still hoping that it will be continued to evolve and to be adopted nationally.
Yeah.
And we're actively looking for that.
Yeah, I mean, I think one of the things to kind of say that, I mean, obviously, as you saw, I presented that a number of services did carry on using Adapt, but a number of services different, and some of that decided to stop, and some of that was, you know, related to the, the coming PRM's system that, you know, was being introduced across New South Wales. But I think that the exercise, I would say, from, you know, exercise with the staff in terms of preparing and thinking about all the things that needed to be in place and all the things you need to think about when supporting, you know, routine screening of any format, and thinking about those referral pathways was a really good exercise. And we know that there's a couple of services that have gone on to continue screening in some way and have used and found the structure of, you know, thinking about, and the structure of what you needed to talk about, all those logistics, what you needed to put in place was really useful. So we're really hoping that even if people don't go on and continue using the Adapt portal in the same way, that just that way of preparing and having a local team to lead and work together has been really helpful, because that aspect of, you know, pre-implementation planning is so important. But I guess we'll see. We'll be able to tell you more about that and how it kind of looked in terms of the adherence to the clinical pathway components more in more detail shortly. But I do think having that local ownership and the team working was a really valuable exercise that services all appreciated and enjoyed working together in that multidisciplinary way across admin, IT, clinical, medical, nursing, psychosocial, psycho-oncology and allied health. So that was really valuable. Yeah. Okay, well, I think that we've probably come to the end. I mean, the last thing I want to do is to thank all of my presenters. I know we've all been very nervous to actually present live for the first time. We've all been so good at preparing recorded conversations and recorded presentations. So I would like to thank, Sharon He for presenting, Dr. Sabina Vata, Dr. Mona Faris, Associate Professor Joe Shaw, and Jackie Yim, almost doctor, I want to say, but not quite, but we'll see. But yeah, thank you very much for presenting live. I know it was all a bit nerve-wracking for everybody, and I hope that all the audience can bear with us fumbling over our words and not being able to correct them by hitting pause on the record button for that time. But we really hope that you found this useful, and we encourage you to look at our publications that are coming out and keep watching this space, and we hope you'll feel free to share your comments and thoughts about the program with us. We'd love to hear what you think about what we've been doing. Thank you very much.
Okay.
And thank you PoCoG for the opportunity.